First speaker. Ivo Петров. Şimdi sorabilirsin translation, работата, cardiovascular, treatment of aortic arch.
Dear colleagues and friends, thank you very much for the opportunity. It's my honor and pleasure to be here and to present our paper, nothing to disclose regarding this presentation. So, aortic dissection is a challenging disease, challenging situation. Still, high mortality rate is characteristic despite the very well established guidelines. Additional conditions, clinical and anatomical, are worsening in many of the cases the final result. Probably the most important is after the classical surgical treatment, the false lumen growth is an independent predictor of long-term mortality and aortic events both in type B and type A dissection. What about redo aortic arch interventions? In fact, among the patients with type A dissection operated on the classical way with partial or full aortic arch replacement, up to 15% of the patients after ascending aortic surgery will require reoperation involving the aortic arch. And this is in fact increasing the risk significantly, even in teams with high aortic experience like Rochester, Minnesota Mayo Clinic team, as shown in this publication from 2014. They had 8.3% of mortality and 5.4% of very procedural strokes in this very experienced team. What about endovascular? Endovascular option is gaining popularity. There are some small series combining surgery and hybrid operation, and this meta-analysis showed promising results with totally endovascular options. And also in the guideline, it's recommended in repeated aortic interventions endovascular to be preferred as class 2A, and also in complex cases in which they have malperfusion, also totally endovascular or hybrid situation is also preferred. On such a way, we have moved from the classical surgical way, from the pioneers, to the new era that in fact started with the Ukrainian surgeon Nikolai Volodov, who was the first one to make endovascular intervention for this thoracic aorta dissection. And speaking about endovascular, the more we go to zone 0 and zone 1, the more complex is the endovascular procedure itself, because in this landing 0-1 requires special techniques for cerebral vessels inflow provision during the implantation of the stent graft. What are the options? The hybrid approach with the branching, bypassing, transposition and so on. In most of the cases it requires short cardiopulmonary bypass and partial sternotomy. So still is a relatively surgical approach. Regarding the branch and fenestrated grafts, physician modified or on the shelf, the problem with them is the extremely high price and the fact that not always available sizes for usage in ad hoc emergent cases. The totally endovascular options always available are in fact three. To implant a large size aortic bear stent across the brachiocephalic vessels in the arch, to have brachiocephalic vessels chimneys assisted TEVR, or to have in situ retrograde fenestration from the brachiocephalic vessels through the stent graft. In our growing aortic experience, more than 800 cases performed endovascularly, we performed in fact the three options. Here is the published material with multi-layer flow modulation, implantation starting from the coronary arteries in a young gentleman with aortic dissection, going to the renal arteries with excellent, nowadays 6 years, excellent clinical result and also imaging result. Speaking about chimneys,